My first.
My first time?
My first big exam.
My first surgery.
Oh yeah, that was crazy.
I didn't know if I would stay. My first intubation.
My first real patient.
My first lumbar puncture.
My first suture.
Oh, yeah, my first cadaver.
When you sign up to deal in lives, death comes with a package. Sometimes peaceful, all too often traumatic. Death is the final score. But what do you do when the loss feels like your own? When the primary goal is to sustain life, how do medical schools prepare students for coping with patients' deaths? I'm Faith Aaron, and you're listening to My First Cadaver. Stories of grief, feelings of futility and doubt, and everything from humor to befuddlement to stark insights emerge through the lens of time and hindsight in the conversations I had for this episode. Today, we begin with Dr. Michael Cords and a little humor. Because how do you really know if someone's dead?
My first real patient death that I was the person who had to really call the death, and it was, up to me at that point, was when I was an intern. And one night I get a phone call on the SpectraLink phone, which is a phone that only works in the hospital. And the nurse is like, please come check them quickly. I don't feel a pulse. I don't feel a pulse. So I'm running over there, and I get there. And here I am, the only doctor who comes in there because it's like 2 or 3 o'clock in the morning. No one else is up. And the nurses are all sort of pushing me just to say, pronounce them dead. I'm scared as anything to pronounce them dead. I don't have a stethoscope or anything like that. I mean, I didn't really bring one. Doctors probably should have one. But what am I going to do with it? Pretend to listen to lung sounds. And I never knew how to use one of those things. So here I am all nervous. And all I did was quickly try to feel for a radial pulse. And I'm like, I don't know. I'm like shaking them. I'm a little like, are you alive? What's going on? So here they are trying to pronounce them dead. I'm like, okay, we'll pronounce them dead. And I walk out, I'm like, this is really going to end bad if they're not dead. What sort of doctor doesn't know if a patient's alive or not? So I'm like getting all sweating and tachycardic. And once everyone leaves the room, I'm going back in there like poking him and trying to make sure that he's really dead. And I'm like telling the nurse, can we get an EKG or something? I don't know. Really make sure. His pulse ox isn't reading. I'm checking his pulse ox, making sure it's on well. Because I didn't want to be the guy who pronounced someone dead when they really weren't. Turns out he really was dead. So then I wind up calling my senior on that night. So I call her up. She's like half asleep, 3 o'clock in the morning. I'm like, so if a patient dies, what sort of paperwork do we need to fill out? She's like, is there something I should know? I'm like, no, just wondering. Just got to fill out some paperwork. So, I was nervous about that too, because now I got to fill out paperwork for a death thing. And I hope I didn't mess that up. And then my senior resident really didn't even question why I'm calling about a dead patient. So, it's always good.
You'll remember Dr. Christopher Carrubba from his intensely awkward OB-GYN encounter. Here he is again.
We were on cardiology, and maybe this will sound like some black humor, but I remember meeting this guy. We admitted him in the ED, and he just looked like a fucking gargoyle. And it was like breathing like one and talking like one, and was this like cross between like a gargoyle and this like crotchety old man that was just like, anytime you asked him a question, what the fuck did you say? What the fuck did you say? And then I think, maybe it was hospital day 2 or 3, my, eventual wife was, fiance at the time, in town visiting because we were doing long distance that year while she finished up med school. And I just remember kind of like having that like, I'm in a hurry to get out of here mode, making sure everything was done, crossing all my T's, getting everything out. And, this guy had been healthy, stable, doing pretty well despite, being admitted for a heart failure exacerbation. And for some reason, we had ordered an afternoon BMP on him, basic metabolic panel. We were diuresing him a lot. I think it was probably just to make sure he wasn't getting hypokalemic. Somewhere in there, I never remembered to look to see if it was back. And I don't really think that I told anybody else, like, hey, take a look at this. Over the course of the night, this guy had cardiac arrest, got intubated, multiple rounds of CPR all night. And, you know, you just come walking in that next day and you see that this guy is like, you know, just had went to shit. Tubes in and out of everywhere, had gotten CPR all night. And our fellow, like, comes up, grabs me, pulls me aside, you know, shows me the lab, and he was like, what is this? Like, you know, what the fuck did you do? And there was just that, like, overwhelming sensation of, like, oh, shit, I did something wrong. Like, I messed this up. The thing is, I mean, like, later it comes back, the lab was actually an error. He didn't have hyperkalemia that, you know, I missed and didn't tell anybody about. It was just a total lab error. But it never, like, went away. Like, it never went away that this person died and it was my fault. And, you know, I don't know, I'm not really somebody that gets that upset, but, you know, multiple times throughout the day, I had to, like, go to the bathroom because I was, like, on the verge of crying. There was just that always thing that stuck with me, that regardless, it was my fault. And now it's just something where, like, I can never get past it. It's like I always have to check the labs like 2 or 3 times. And I think it really is one of those things that makes you probably a better doctor for it. Because, you know, I think beforehand I could be a little haphazard and I really could let things slide. And just knowing what that felt like really, like, just never went away for me, you know, never really went away.
Let's go to Dr. Daniel Maselli with more on his first patient death.
The first patient death, it was on my internal medicine rotation, and it was on a weekend, and it's like this beautiful fall day, and I remember driving past this flea market and thinking, like, oh, that's awesome, I'm going to go check out that flea market when I get out early, and I'm totally leading the witness here because, spoiler alert, I didn't get out early that day. Instead, I found that my team was unaware. They were unaware of this policy of med students being let out early. And as a third-year medical student, I was not ready to advocate for myself because these, you know, you want to impress your team, you want to get good grades so you can do well, so you can go be a resident and be a good resident at a good residency and then get a job and then pay off your debt and get married and get a dog, which is the ultimate goal, I think, of all of this, the dog part of that. And I was super psyched to go be able to show off my medical skills in this medicine rotation. So I was not going to say, may I please be excused because of the policy that UMass has in place. So instead, I stayed quiet around 1, 2 p.m., the time that I thought that I would be being dismissed. And around 3, we were paged down to the emergency department because we had 2 admissions. And one was an elderly woman with a GI bleed. So she, somewhere in her gut, there was a source of bleeding, and it was not stopping. And the other was a gentleman who was fine until a couple of weeks ago when he really just started getting very short of breath, and he was a smoker. And they took x-rays of his lungs and CT scans of his lungs, and they were just, man, they were cobwebbed with the spread of cancer like nothing I'd ever seen. It looked like it had even gone down to the liver to metastasize. And the tubes that were keeping this man alive by pumping oxygen into his lungs, they were just, you know, they were working overtime. I think they were just barely keeping him hanging on. He was out. And this woman who was in a GI bleed was out too. They just didn't have enough mentation to be aware. So I didn't even really get to meet them. I mean, I was present, but I never heard them speak to me. And that's always kind of a bummer, especially for someone going into internal medicine where histories are just such a rich, important part of your experience. But what really got, I mean, the thing that got to me about that night, again, wasn't the patient's death. To be honest, I was dismissed around 9 p.m. before either patient had died. They actually died sometime early in the morning the next day, both of them. But the part that just got me was the families, because the families were the ones I had interacted with, were the ones I had interviewed to take the history. And for this gentleman with the lung cancer, his wife was present, and she was calling her children to come say their final goodbyes. And meanwhile, that old lady's family was already in the midst of kind of saying their own. And the most salient memory for me was to see her husband kind of do this solemn march around the ICU. He couldn't be in the room with his wife. It was too much. So he was sort of just walking around the room with the support of a cane or the support of a grandson. And that just got killed. That got me, because that was such a sad image. And you really realize that when you're treating patients, you are treating their entire families. And I thought, okay, well, I don't know the patient in front of me, but I certainly know all these living patients who are related to this woman in a GI bleed or this man with lung cancer. And to see them suffering and to feel kind of powerless to do anything about it. I mean, even if I weren't this third year clownishly oversized medical student, like, I wouldn't really be able to do anything as a resident. There's not much you can do medically at that point except for comfort, which is still something. But I remember that, seeing that older gentleman walk around the ICU, that's when I knew things were really going bad. And I dismissed myself to go into the bathroom and just cried into a fistful of paper towel, because, man, that was powerful. I was not ready for that on that day. And, I am grateful that I did get to stay those extra hours, that my team, didn't dismiss me when I thought I was going to be dismissed. Obviously, I missed the flea market, but it was a really moving part and a very instrumental part in solidifying this concept that internal medicine is where I want to go, because being around these patients and their families in this time of need and comforting them even when medicine is just out the window, there's nothing more you can do, but just being there for them, like my residents and the attending were, man, that was a very powerful thing. So that was the first. The first patient death was 2, and I wasn't even present for it, and I didn't even know the patients really, and yet it still sits with me as one of the most moving experiences of my medical school career.
So in my medicine clerkship, my general medicine month was on a step-down unit, which is basically an intermediate level of care between the intensive care unit and regular general medicine floor. And so my patients were sicker than most of the students who were on general medicine.
That's Dr. Sarah Coates, a graduate of the WEILL Cornell Medical College.
We had a man, an 85-year-old gentleman, come in who had been in really good health most of his life, and he had a pulmonary embolism over Christmas, and this was a couple months later. And just since he had that pulmonary embolism, he just kind of went downhill. And what they came to find out through imaging was that it wasn't just that he had a PE. He had this underlying restrictive lung disease, which is this fibrosis, this hardening of the lungs, and it's really hard to treat. And people tend to go downhill really fast. And what was crazy is that he had been fine until he had this one trigger that was wrong with his lungs, and then everything else kind of came uncovered. And I think it was just so hard for the family to understand how someone could go from being so healthy to all of a sudden having a really serious lung disease that's supposed to take years to kind of accumulate and manifest. And trying to explain to them what restrictive lung disease even was something that I found challenging, and I tried to do it. And I would get up on the whiteboard and I would say, like, this is what your lungs are doing. They're having a hard time expanding. And that means that it's really hard for you to breathe when you move even a little bit. And that was exactly what he was experiencing. And over the course of 2 weeks with us, he just precipitously declined. And I just remember there was this one moment where we could have done a diagnostic test to confirm that he had this type of disease, and that would have required us to go in and take a biopsy sample. But since he was DNR, DNI, do not resuscitate or intubate, the pulmonology team, who said that they wouldn't treat the disease unless they had a biopsy, they didn't want to go get a biopsy, because if something were to happen during the biopsy, we wouldn't be able to help, and you would feel as though you triggered the situation that led to his death. And so we were in this catch-22 where we couldn't treat him with the big guns unless we had the tissue, but they didn't want to get the tissue because he was DNR DNI, and so they're just letting him slip away. And maybe I'm oversimplifying this in hindsight, but at the time it just seemed so like Alice in Wonderland, weird to me. And on top of that, people were saying like, there's no need to like draw stuff on the board for them. Like it's not necessary to go into such detail about what's going on. We're not even sure what we're going to do about it. So like them understanding it more is not going to help. And that was one of those moments where you just feel so powerless, and yet you get this sense that you're the only one who really cares. And as self-righteous as that sounds, I think that's what third year feels like a lot. So I was there as he declined, and when I went away on a Friday night, I was hugging his daughter and telling her goodbye because I was not going to be there the next day. It was my day off. But I just remember on my day off checking the patient record from home while I was doing USMLE World questions, and watching as notes were getting dropped from like the palliative care team and the ethics team, and you know, the morphine was being ordered, which meant that they were going to try to ease his pain at the end of life. And it was clear what direction was going just from watching the notes getting dropped in the chart electronically. And I felt so weird and selfish and creepy because I thought, I'm going to get there and he's going to be gone. I just want to be there. Like, I know this guy so well. I should be there when he dies. That's not cool. And I get in the next morning on a Sunday and he's still alive, but only hanging on. And he dies a few hours later that morning. And it was so hard to watch because his daughter, she just lost it. And she was like crawling on his bed and screaming like, "Daddy, Daddy, Daddy." And I'm just like, I'm losing it. My intern, I don't know how the hell he's keeping it together, but I'm like trying not to move, but tears are streaming down my face. And then the family leaves the room and we have to do the death exam. And the death exam it's not horrible, but it's brutal. Like it's very much in your face. It's like going back to the anatomy lab almost, because you're doing things that you would never do to a live waking human. You're squirting water on their face, or, you know, touching their eyeballs with cotton, or jerking their head from side to side to see if their eyeballs respond. And it's so surreal to have that connection with someone, and then you have to treat them like a cadaver and basically confirm that they're no longer alive. And I was crying while I was doing it. And the whole time I thought to myself, like, this is why I can't do this. This is why I have to be a dermatologist. I'm just way too emotional to handle this day in and day out. And if I am not too emotional, I don't want to get to a point where I'm so hard that this doesn't affect me this way. Like, how does anybody do this? And we ended up coming out of the room and confirming his death. And the daughter, I'll never forget, she just said to me, like, "I'm so glad you were here. I'm so glad you were here." And I'm thinking, me being here didn't make a difference. Like, he was already gone when I got in this morning. He was already almost there. But I think it just kind of showed me, she knew how much I tried to make them feel like they knew what was going on. And as helpless as I felt during that whole situation, that communication that she had with me made me realize, like, even if I didn't teach them exactly what was going on, and even if I felt frustrated the whole time, like, she was noticing. And she was grateful to feel like she could talk to someone on the team. And it's moments like that that make you feel really conflicted. It's like I said, I can't imagine how anyone could do this over and over. But then I thought to myself, maybe they need people who are so emotionally invested to do jobs like this. But ultimately, I decided that that level of intensity was not something that would allow me to function professionally on a day-to-day basis. I think it was just too hard to get so close to people and then watch them die.
You know, it's a funny thing about death. It's not that funny. And sometimes it's not as easy as you think. It can be hard to die for the patient, the family, and even the medical team. It can be grueling and long and drawn out and tedious, and it's always, always sad. It's a wonder the planet isn't overflowing with dermatologists or podcast hosts. It takes a special person to be there at the end, to hold the hands and check the pulse, to do the death exam, to sign the forms, to do that job, even on a random rotation as a medical student or an intern, awaiting dismissal and dreaming of dogs in flea markets, an accidental witness to the end of a world. It takes special people to share these moments of intimacy, of recognition and understanding, of accepting what kind of person you are and what kind of doctor you will be. So maybe the funny thing about death is how much you can learn about the rest of your life. Thank you to Doctors Michael Cords, Christopher Carrubba, Daniel Maselli, and Sarah Coates. The My First Cadaver team, Papa Claire Music and Compulsion Music, our Nerf blasting friends at Salted Stone, and special thanks to Robert Meekins, who is not a doctor. Stay tuned for episode 4, my first oh my god, no fucking way, coming soon to a listening device near you. And remember, guys, don't jokingly pretend to fall into the Grand Canyon, or you could become someone's first cadaver.
You know, it's always good.
I take it you weren't the one who was responsible for doing the death exam?
No, not that's pathology, but I pronounced them dead, and I filled out the paperwork. I was just hoping that they actually were dead, I guess. I mean, based on what, my poking them and trying to feel for a pulse? I mean, maybe they were passed out and they're on beta blockers or something, you know?
This episode of My First Cadaver was sponsored by your friendly neighborhood med school tutors. Join our tutor ranks and pay it forward, while you pay it off. Let med school tutors be a part of your origin story. Together, we can save the world.